Good evening and welcome to this evening's CaringKind and Rabbinical Alliance of America presentation, Al Tashlichenu El Eis Zikna, what rabbis, rebbetzins, and chaplains need to know about dementia. Wednesday, July 27th, 2022. My name is Rabbi Yehuda Blank, though many know me as Rabbi Leonard Blank. I am the Director of Programming, Chaplaincy Commission, and External Affairs for the Rabbinical Alliance of America and moderator for this evening's presentation. Please note that all participants are muted and questions can only be submitted via the chat. This webinar is being recorded and will be available on the Rabbinical Alliance of America website. I want to offer sincere thanks to Rabbi Mike Schmerler and Rabbi Gil Student for their expertise. CaringKind is New York City leading expert on Alzheimer's and dementia caregiving. The mission of CaringKind is to create, deliver, and promote comprehensive and compassionate care and support services for individuals and families affected by Alzheimer's disease and related dementias, and to eliminate Alzheimer's disease through the advancements of research. They achieve their mission by providing programs and services to individuals with dementia, their family, and professional caregivers, increasing public awareness, collaborating with research centers, and informing public policy through advocacy. The Rabbinical Alliance of America, also known as the Igud HaRabbanim, is one of the oldest rabbinical organizations in the United States of America. Our goal is to inform, to educate, to present the latest, important, and often finger on the pulse topics, programs, and resources that are vital for rabbis, rebbetzins, chaplains, and other professionals, beneficial for the meaningful work they do with their congregants, their communities, and for themselves as well. Adina Segal, LCSW, is the Orthodox Jewish outreach social worker at CaringKind, where she provides emotional support to individuals and families affected by all forms of dementia. Adina is passionate about helping people thrive through difficulties and has worked with family caregivers over the past 13 years. Her past experience include serving as caregiver program director at Heights and Hills in Brooklyn, as well as practicing clinical work at Jewish Board of Family and Children's Services and OHEL, Children's Home and Family Services. She holds a BA from CUNY Queens College and MSW from NYU School of Social Work. The Rabbinical Alliance has and continues to partner and collaborate with major organizations and is proud to do so with CaringKind. Should there be any questions that were unable to be answered this evening regarding this webinar or questions of a personal nature for Adina Segal, please contact her at the email provided this evening. If there are any questions pertaining to the RAA, my contact information is also being provided. On behalf of Rabbi Mendy Marachnik, Executive Vice President of the Rabbinical Alliance of America, I now present to you Adina Segal.
Thank you. Thank you, Rabbi Blank, and it's a real honor to be here. I'm really excited to be giving over this, I think, very vital information for our kahilas. Let me just get my slideshow up and we will begin. So as I mentioned, or as mentioned already, this webinar is Al Tashlichenu Le'eis Zikna, what rabbis, rebbetzins, and chaplains need to know about dementia. As mentioned, my name is Adina Segal. I am the Jewish outreach social worker at CaringKind. So one thing that's important when it comes to thinking about dementia is realizing that dementia is actually not an actual illness. It is a constellation of symptoms that's caused by an illness. These symptoms affect 4 areas of functioning. The main one that I think most people are very familiar with is the impacts on memory, particularly short-term memory. Later on, it goes to longer-term memories that are impacted. But it also affects things like cognition, like the way a person can think and plan and use logic. It can affect changes in behavior. You can see really rampant mood changes, a lot of agitation. You can see major personality changes. I mean, it's not unusual to hear of a story where somebody knew, a family member knew that somebody, their family member had dementia because they were always such a sweet person, and then suddenly they just get really nasty or really their behavior just completely the opposite of how they were known. It also ironically can happen the opposite direction, and I have seen this happen. It's not as much, but where you might have somebody who has always been kind of known as a nasty person, and suddenly they get really sweet and docile. That can present its own interesting issues among family members, but that is also not an uncommon occurrence. But we're really thinking about just global personality changes. And lastly, and especially given the fact that dementia affects the brain, and it's largely brain diseases that cause it, it will impact physical functioning. So, especially in the later stages, you're going to have people who have issues with motor skills, with the ability to walk, with balance, even with like fine motor coordination, like being able to use a fork and knife or being able to button a shirt. Those things all get impacted. And dementia is basically, as I mentioned, a syndrome. It's caused by a medical condition. So when we're talking about Alzheimer's disease, we're talking about dementia that is caused by Alzheimer's disease. I'm going to go into the other forms of dementia as well. There are about 120 different forms of dementia. Some are reversible. I'm going to touch a little bit on that. I'm also going to touch on the top 5 irreversible forms of dementia. Another major question I often get from people, and especially among people who are already providing care to somebody who has dementia, is, well, how do I know that, what I'm going through is any memory issues that I might have is normal aging and it's not dementia. It's not, oh my gosh, this is happening now. And so we all occasionally misplace our keys. I know I definitely fall into that category. It's when you forget how to use a key, that's already a sign that there's something more going on. It's not simple aging. We're really talking about a warning sign of dementia. Forgetting the right word is also something that, happens to a lot of us, especially when we're anxious. You have that sort of tip of the tongue syndrome. But it's when a person's having difficulty following a conversation. Either they can't follow a conversation, they may have trouble getting their sentences out or completing their sentences, completing their thoughts. That's already something that's more of a sign of dementia. We all will temporarily forget the day. I find for myself, especially after a major vacation or a chag or anything like that. It's very easy, when it's Monday and you're wondering if it's Tuesday or something like that, that often can happen. But it's when a person is losing track of the date or the season. If you're thinking that, it's 2000 and you're thinking you should be doing that routine instead of your current routine. Or if, it's really hot outside and, a person is thinking that they need to put on their winter coat, that is also definitely a sign of concern, and it is not normal aging. I also just want to make a caveat that even with all of these considerations, the main concern that family members should be thinking about or individuals should be thinking about is, does it impact a person's functioning? Even with the misplacing of keys, I have had clients where they might misplace the key several times a week, not be able to retrace their steps, and are literally calling the locksmith 4 or 5 times a week. That's already impacting their functioning. That's not, simple aging. That is, more of a cause of concern. So we're thinking both on just the degree of the cognitive presentation, but we really do also want to consider how is this impacting someone's functioning? Can they continue their day-to-day routine and keep up a normal life and their normal activities. So as I mentioned, there are 120 different causes of dementia. Some are reversible, some are irreversible. It gets very interesting because a very common question that people ask is, well, what's the difference between Alzheimer's and dementia? Or I'll hear, oh, well, thank God they only have dementia. It's not Alzheimer's. I've heard that several times. Dementia is more of an umbrella term. There, as I mentioned, there are 120 different causes. So it can be Alzheimer's, but it can be something different. As I mentioned, there are reversible dementias. The reversible dementias are things like vitamin deficiencies, medication interactions, unfortunately, brain tumors, and that can, I call that reversible because, you know, with treatment, you know, either the person can get back to their normal functioning, or maybe it'll just kind of stay the same, but it's not going to have that downward decline the same way that you'll see it with the reversible forms of dementia. Also, another very important one, thyroid conditions are another cause of reversible dementias. And another consideration, which I think is important both for people who don't have dementia and people who do, are urinary tract infections. As people get older, they experience urinary tract infections differently. They may not experience pain or things that younger people experience. It may look like delirium or like a real rapid decline in their cognitive functioning. And this can happen to people who don't have dementia. It is really important if you see that somebody, you know, is having a rapid decline like that, that they get seen by a doctor, because a course of antibiotics will clear up the urinary tract infection and the person will be back to the way they, you know, the way they always were. This is also true, however, for people who have a form of dementia. They may have their baseline way of, you know, behaving or interacting, and you'll see a sudden decline. It's really important also to get checked out for urinary tract infection, because once you clear that urinary tract infection, then they're back to, you know, the way they were, so their baseline. So that's an important consideration just in general as people age. In terms of the reversible forms, so we have the top 5 up here. Alzheimer's disease is the #1 cause of irreversible dementia, followed by vascular dementia, which is caused by, you know, cardiovascular and cardiac issues. Lewy body dementia, which is sort of a Parkinson's-like dementia. It's dementia. It's like a combination of Alzheimer's and Parkinson's that kind of happen at the same time. Frontotemporal dementia, which largely affects language and also more behavior than memory. And then unfortunately, there's also mixed. It's not unusual for somebody to have more than one type of dementia at the same time. I think the most common one that at least I've read and seen is usually like Alzheimer's and vascular dementia. So that's not an unusual combination. So, oh, and so as I mentioned, I went through the other forms. In terms of it, I'll do a little bit of a deeper dive. So when it comes Lewy body dementia, I will mention it can be kind of tricky because at least in the beginning part, somebody might have been diagnosed with Parkinson's disease, and only later on will have a Lewy body diagnosis. And that's really because with Parkinson's, there is a dementia that follows with Parkinson's. The difference is that it's usually at the very later stages of Parkinson's. With Lewy body, it happens early in the Parkinson's course of illness. Within the first 5 years of a diagnosis is usually where, you know, when somebody will be diagnosed with Lewy body, because that's not usual for Parkinson's. And the initial symptoms of Lewy body will be things like sleep disturbances, visual hallucinations, Parkinson's-like symptoms, which are, you know, the tremors and muscle rigidity. And those are things that will happen on top of all the memory problems that, you know, can occur as well, and the cognitive issues. Vascular dementia is a little bit different than all of the others because there it's caused by microscopic bleeding or blood vessel blockages to the which block oxygen to the brain. Those are usually, they're called TIAs or trans-ischemic attacks. It's stroke activity, but it's usually happening on such a microscopic level that a person may not even know, or other people may not be aware that there is some sort of stroke activity happening. And it is only really seen on like an MRI or a CAT scan. The location of the injury will determine the change in functioning, but usually the initial symptoms will include, difficulties using judgment or the ability to plan. Also, it will, another common one that I see is apathy, just like not wanting to get up or get out of bed or do anything like that. And then frontotemporal tends to happen in younger people, like people in their 50s and 60s. The initial symptoms will often include the major changes in personality and behavior. Their memory is generally intact. What really happens in frontotemporal is that whole front brain part of us, which is responsible for logic and reasoning and empathy, being able to take another person's perspective, gets majorly impaired. And I've heard from people who have taken care of people with frontotemporal that they feel like it's almost like you're taking care of a toddler in terms of their reasoning skills. The other major component of frontotemporal is language. So somebody might either present with major behavior issues or language problems, very global language disorder, where they really can't speak clearly and coherently. And as I mentioned, the symptom onset is earlier. The life expectancy is shorter. It is a shorter course of illness than the other forms of dementia. And as I mentioned, it can also happen mixed. So here's a list of the top warning signs that happen that can be a sign of dementia. So as I mentioned, memory loss that disrupts daily life. I think that disrupts daily life is the most important component of thinking about memory loss. Difficulty planning or solving problems. Forgetting how to do familiar tasks. People in early stage of Alzheimer's or other dementias will have trouble following a short shopping list. I had a case once where a wife sent her husband who was in the early stages to the grocery store, and she gave him maybe like three items to get, like milk, bread, and eggs. He comes home with 2 cartons of milk and 2 bouquets of flowers because he felt so awful that he couldn't, follow the list and get her what she needed. So that just to show just how that's illustrated. Confusion with dates, times, or place. A person can wake up at 3 o'clock in the morning and start thinking it's time to go to work, and start acting like they have to go to work. A person may be on the way. I had a case where somebody was getting lost going to the job that she's had for 25 years. These are all definitely major warning signs. Withdrawal from work or social situations, or difficulty initiating activities. This is a little tricky because dementia and depression can kind of overlap. Especially in older people, depression can cause memory issues. And if somebody has memory issues, they take an antidepressant and it lifts, then it was depression. But oftentimes, either a person can have dementia and be depressed, because either they know that they have this difficulty and that they're losing their abilities, and that's depressing. But also a symptom of dementia is apathy. So it may not even be that they're depressed, but it may be that part of the brain that motivates you and gets you going and has you initiating activity might be the part that's impaired with the disease. And so therefore also that's causing that withdrawal and that apathy. Misplacing objects and the inability to retrace steps. I would also add, putting things in places that don't make any sense. Like, somebody comes home with their groceries and they put chicken under their bed. Really kind of things like that also can be a warning sign. Trouble with spatial relationships, not really being able to tell, where things begin and end. And there might be difficulties with showering because they have trouble seeing the water. In fact, showering is a very common issue, and there can be a lot of different reasons. One of the reasons that there's an issue is because people with dementia experience water differently, and it's a jarring experience for them, and that can be because they don't really see it well. Another thing is, if they see a black mat, sometimes some people will think that it's a hole. So there might be some issues with visual spatial stuff. New problems with words and speaking or writing. They may not be able to finish their sentences. They may not be able to name common objects. Something like, calling a pencil, the thing you write with, sort of defining it instead of using the actual term. Mood swings and changes in personality, altered decision-making, poor judgment, or relying on someone else like a spouse to make decisions. A lot of times spouses will cover for the other spouse who has cognitive issues. And, so most people, including their own children, may not realize that anything is going wrong because, that spouse is covering. What unfortunately is not an unusual occurrence is that once that spouse should that spouse predecease the spouse, which is also something that statistically often happens because caregiving spouses don't take care of themselves particularly well because they're busy caregiving. They, should they predecease that person, then suddenly the children come and see that, that parent that was being cared for is much far gone in their dementia than they were led to believe. It's not an unusual thing at all. Another thing in terms of decision making to keep in mind is susceptibility to scams. It is very, unfortunately, a very common experience. I mean, unfortunately, nowadays, I find that scammers are getting more and more crafty, and even people who have their full cognitive capacities can get caught up in a scam. But oftentimes people with dementia in the early stages especially will get involved in like very simple scams that you can kind of see through, like somebody who will, they'll have a scammer call them on the phone and they'll say, oh, well, if you give me $250, then you'll win $5 million. And then, the person thinks, oh, this is great. And they actually follow through with it. And it can lead to a whole slew of problems in terms of getting involved with scammers and scams. So that's also not an unusual occurrence. So the way we at CaringKind, there are a lot of ways people conceptualize the course of this illness. We conceptualize it as in 3 stages: early stage, middle stage, and end stage. There's actually also like a preclinical stage, which is mild cognitive impairment. But that's where you might have somebody might have memory issues that are, they're pretty apparent, but they're not enough to impact their functioning. So they're still able to go shopping and cook and manage their medications and pay their bills. It just might be that their memory is shot. They have to write everything down. They may not remember names, or they may not remember meeting a new person, but they can pretty much function. For people who are in that category, 40% of them may stay, in mild cognitive impairment. They may not move on to another form of dementia, but about 60% will. So there is a higher risk for people who have mild cognitive impairment. Assuming that one does go on, then in the early stage, that's really where you'll see, difficulties with money. It could be that they have difficulty paying their bills. It could be that they have they may forget to pay their bills, or they may forget that they paid their bill and double or triple pay their bill so that there's no more money in the bank. As I mentioned, scams are another major issue. And I know a number of years ago, there was an article in the New York Times that basically was highlighting that the number one reason why families ask for help and when they know that there is an issue, it's usually when, a parent is having difficulties with money. So just something that I found very interesting and in my own clinical experience, true. Mismanaged medication. They may not be able to take their medication anymore. They may be taking too much of it. They may be forgetting about it. They may have difficulties with or ignoring their personal hygiene, not wanting to shower, maybe wearing the same clothing for days on end, and also, not remembering to eat, or not remembering that they ate and wanting to eat, fairly constantly because they don't remember eating. In the middle stage, it progresses a bit more. The bigger concerns are wandering, where a person, can lose track of where they are. The most common thing that I've seen and heard about is people in this stage who will say that they want to go home. And home is kind of, they experience it as going home. I think what they really are looking for is for things back to the way they used to be. But, conceptually in their mind, it's going home. And so there's usually a big concern around wandering at this stage and trying to prevent wandering. We actually have a program with Medical Alert that provides a bracelet with, engraved on the back saying, this person has cognitive impairment, there's a number, and then there's the Medical Alert number. So if somebody finds them on the street, they can call up the number, give them the tracking number, and then they can be paired back with their emergency contact. And the good news is that the police and emergency responders also have access to this database. So it really cuts down the wandering time, because if somebody wanders for more than 24 hours, the outcomes are usually not so good. So we really want to try to reduce that. And we, Baruch Hashem, we've been able to really help a lot of people with that bracelet. But even if a bracelet is not the right thing for somebody, we don't have, but there are GPS products on the market, and there are different types of confounding locks and alarms and all sorts of things. It's really kind of an individual, the family has to really figure out what individually works for them. That's why calling me or my colleagues is a good thing. We can help them work through that. Another major thing that happens in the middle stage is what's known as sundowning, which is sort of like at the end of, or middle to end of the day, like anytime after 2 o'clock, a person with dementia can get very agitated. They may hallucinate, they may not be able to sit still, and it can be very, very difficult at the later part of the day. This can be attributed to changes in the circadian rhythms, which happen in Alzheimer's disease. And so, in the mornings, more often than not, people can kind of keep themselves together when they have dementia. That's why, we recommend if there's anything important to do, you do it in the morning. And then by the end of the day, they're usually, or even the middle of the day, they're usually spent. They just can't keep it together anymore and they're exhausted. And so, we really trying to keep the later part of the day more relaxing, playing, music that they like or that's relaxing is also, can be helpful. There are a couple of other techniques, but that's really for another presentation. Paranoia also can happen. Disorientation to time and place. And at this stage also, you start getting difficulty with recognizing, or you can start getting difficulty with recognizing family members. They may confuse a daughter with a sister, or have difficulties with remembering various grandchildren. These are things that can start happening in the middle stage. Another thing that also happens in the middle stage is the beginning of issues around incontinence and toileting. And so at this stage, a person really needs, if not 24-hour care, definitely a lot more care than they might need in the early stage. And by the end stage, a person's pretty much bedbound. There are feeding difficulties. That's really where more of the body shutting down, and they're not really verbal. And the major concerns really are around comfort. And I would also argue, around safety is always a discussion, but when it comes to this is at the end stage, usually this is where there's discussion around, is a nursing home the right place? Can we really even physically accommodate the person's needs at home? These all become major considerations. So, I do a lot of work with caregivers. So my concern is really, it's about the person, but we also do want to keep in mind that there is a caregiver and there are things that they're going through. And towards the end, especially given the fact that this person can get so impaired, they're really very dependent on the caregiver. So we really want to keep that in mind and support our caregivers. And when it comes to what they're facing with all of this, we're talking about really significant physical, financial, and mental health concerns. I was talking to a caregiver a couple of days ago, and the parent that they're taking care of is getting less able to transfer from bed to chair, and the caregiver is starting to have trouble with their back because they're busy trying to get the parent up and transferring. Financial, home care is incredibly expensive at this point. I believe it's at least $30 an hour, and that's just private pay for private pay home care, especially as the needs progress. Financial considerations become a major concern. Another thing that is not uncommon is that caregivers may have difficulty even keeping their own jobs because of the needs of their families. So they also can some of them opt to stay home and take care of the person because that just will be easier, but that will take away their earning power in the future. And it also means that they're not getting the, financial, their own financial needs met. And then on top of that, you have, incredible financial stress just from the actual care. And then mental health as well. I mean, I'm gonna touch on caregiver burnout. Not necessarily that everybody's gonna have all the symptoms of burnout, but there's certainly a lot of things of that nature happening for caregivers. If only just grief and loss. As you see, I have a term here. It's called ambiguous loss, and this is it's a fair. It's not such a new concept, but it's becoming, I guess, more well known. It's becoming more well known now. But ambiguous loss is really where it's grief where the loss doesn't have any finality to it. So it was founded by this psychologist. Her name was Pauline Boss, and she was researching people who were missing in action, families who had people missing in action in Vietnam. And she found that, they were in this weird limbo situation where the person could be alive or could be dead. They're there, but not there. And then she, later on in the course of her work, sort of found the same dynamics happening in caregivers of people with Alzheimer's, where you have the person, they're physically there, but at least mentally, emotionally, and cognitively, they were really not the same people that they were experienced as in their, with their families. And so it triggers that same feeling of loss where, the person's there, but they're not there. This can lead to a lot of family strain. Family strain can also happen with, family role issues, who's doing what. A lot of old sibling rivalry dynamics can come up, from things that happened, maybe like 40, 50 years ago. Suddenly, you're back to, the brother who was the goofball and the sister who was super responsible, and all of the dynamics that you might see in a younger family suddenly start playing out again with an ailing, a parent who has dementia. When it comes to caregivers, it's really important to validate, all of their feelings and to assist them in identifying what they're able and not able to do. Because, I think many of them, and I find in our community as well, that a lot of them do feel like, we should be doing, everything possible for our family. There's a lot of guilt that comes up with things that we can't do, or they feel that they want to do, but they can't do for whatever reason, whether it's because they don't have the physical or financial resources to do it, or they have other competing responsibilities. So it's really important to be able to validate that, they don't have to, they may not be able to do everything, and that, that's just something that they have to just accept, and that's okay. And also try to see if there are other places that can help to fill in some of those gaps. In general, with caregiving, no one person can take care of a person with dementia. It really needs to be a group effort, if only just by having home health aides, but really probably even more comprehensively. There are venues for support, and I think certainly Rabbanim should be aware of the support programs that are available. So there are local areas on aging in New York. There's Department for the Aging. They have a lot of services. They're the ones who fund the senior centers and who funds the Meals on Wheels and things like that. They have caregiver support programs. Alzheimer's Association obviously is one of them, and CaringKind is certainly one of them. I do want to put in a plug for CaringKind in the sense that, at least to my knowledge, I don't know of other programs that are responding, aside from Zikaron, which I work with. I work with them. I don't know of other programs that are responding to the needs from families that are facing dementia. And CaringKind, I know, was asked several years ago, way before I came on, by different organizations in Borough Park about having a designated person, who can address from concerns with caregiving. And they actually worked to get funding for it. And so, Baruch Hashem, in 2019, they actually got funding from, then it was called the Spartak Home for the Aging Foundation. Now it's called the Spartak Foundation on the Aging. They basically fund my work, but I do think it really says a lot about CaringKind that they've been taking these issues very seriously and have made the effort to find the funding to do this. So that's my little spiel on that. But then just other things that you should be aware of. There are home care programs. There are even home care programs that can pay family members to provide home care, which can help for some people. That's called the CDPAP program. And there are also adult day programs. I know of kosher ones, a few kosher ones in Brooklyn. I would love to hear about more and hear that there are more, but unfortunately there are not that many, but there are some, and they are very helpful, because what's great about those programs is that they provide what's called a no-fail environment. You know, when somebody has dementia, you don't want to pressure them. Remember this, remember that. That's really the worst thing, and it just increases the agitation. But you really want them to feel like they're accomplishing something, they're doing something, and it doesn't matter if they fail. There's no yes or no, or right answer or wrong answer. So what many adult day programs will do is they'll draw on using a lot of art or a lot of music, dance, yoga. There was one program that I know of that was actually a program for men, and they would sing nigunim, and they would look at pictures of Rabbis and things like that. So they're just engaging in things that are pleasant, that can bring somebody back to maybe the past and things that they used to do or that they used to be interested in, and that can really be helpful both for the person, because they have a meaningful day and a schedule, and also for the caregiver, because the caregiver can then go on and take time for themselves, take time to care for themselves. I mean, a lot of times caregivers will tell me that they're not going for their regular doctor's appointments. They may have medical things that they're ignoring, and these are all really bad things, and these contribute to the dynamic that I mentioned of the caregiver predeceasing the person that they're caring for, because they're not taking the time to take care of themselves. So caregiver burnout, I mentioned briefly. Some of the symptoms are isolation and withdrawal, loss of interest in things that they used to be interested in. You might see a lot of depression. There might be irritability, a lot of anger, particularly either anger or apathy directed at the person that they're caring for. That's usually a really major symptom that they need to address, because it's bad for everybody. Physical exhaustion, getting sick often, and I would also add to that, being accident prone, changes in eating and sleeping patterns, not eating or overeating, not sleeping, or usually they can't oversleep, but if they might oversleep. And in really extreme cases, it may even lead to some suicidal ideation. It's really important for caregivers to reach out to prevent this, to at the very least, to have somebody to talk to about what they're going through, and at best getting other people involved so that it's not only on their head. Getting a home health aide, getting other family members who might potentially be able to help, or neighbors or friends, whoever would be open and interested in helping in any way. It's really important to try to engage that. So I'm going to focus a little bit on the dynamics of I guess the main players that I see. So I have the well spouse is I think it's a role that we don't really think about very much. And even the well spouses themselves don't think about it very much. They don't think of themselves as caregivers. They think, well, I'm a spouse. This is what I'm doing. I'm taking care of my husband, or I'm taking care of my wife. At the same time, they may be going through some really difficult emotional experiences. They're often grieving the loss of the spouse that they've always known. I think I do hear this with adult children, but I hear it, I would say, consistently with spouses, is just they are dealing day in and day out with the person. They see how they're declining, and it's just a constant reminder of the losses that they're going through, and the loss of the person that they've known. And you're talking about people who have had relationships 50, 60, sometimes even close to 70 years. It can be it is really, really difficult. So the other piece, so I mentioned grief, loss, shame is another common issue that or feeling that a well spouse may have, because the person with dementia may not be acting normally or in a way that's socially appropriate, and so that'll create feelings of shame for them, because it's like, how could they be doing this? How could they be saying this? They've never spoken like this before. Why are they suddenly cursing like crazy? These sorts of things can happen, and the well spouse can really take it to heart and feel very, very ashamed about it. It's also common for a well spouse or a spouse with dementia to pull away and to have some intimacy issues. And I mean, in the sense of even just emotional intimacy issues. I've been hearing more and more about situations where you might have people who are in their 50s or 60s, and then they suddenly are getting divorced, and they've been, pulling away for many years. And then it turns out, well, the reason why was because the spouse was showing personality changes due to dementia, and the well spouse didn't know. But even without such an extreme case, that can still happen. And even once they're diagnosed, they can also pull away, because the well spouse will have that shame. Will also realize there's a lot of stigma involved with dementia. A lot of people who I've spoken to will say, their spouse got diagnosed with dementia, and suddenly, like, all of their friends, maybe they have one person who's still calling, because people get nervous around dementia. They think it's catching. I've actually had this experience where I was at a health fair, and it was a senior fair, and it was amazing to me how many people would see, the CaringKind part of dementia caregiving sign on the table, and they would literally like circle around the table, as if I was going to give it to them because I'm there representing an organization that helps with dementia. So there is a really strong stigma that is most certainly felt by the families and by the spouses. But there's also anticipatory loss. I mean, there are the losses that they're dealing with, and they're also dealing with, well, I know this is not going to end well, and so I'm anticipating the grief that I'm feeling. There's also role change where, you're a spouse, but then suddenly you're a nurse, or you may even feel like a parent. So that can contribute to a lot of strain. And with the spouse with dementia, the apathy or the behavior changes and the personality changes can be really difficult. And even if there is no major apathy or no major personality changes, what I'm hearing a lot from my spouses is that, having somebody ask the same thing over and over again, maybe, 7 times in 15 minutes can really, after a while, get really grating and really difficult to handle. And then they start a cycle of anger and guilt, guilt that they got angry, and then it can get into this real spiral of anger and then guilt and then anger again, that you're feeling guilty. In general, though, for spouses, I think it is important to have a clear understanding of the illness and its trajectory. What it helps, it's difficult because there is a major grief process that happens, but at the same time, it does help to depersonalize the situation. My husband is not doing this to drive me crazy. They're doing this because they have dementia, and this is how it's affecting their brain, or his brain. It could really assist in the way that the spouse can handle the behavior, and also be able to maybe take some time and scale back to take care of themselves. And in general, the relationship kind of does need to be evaluated in terms of, well, how much am I a spouse and how much am I a caregiver? It's interesting because with this ambiguous loss, what Pauline Boss says is that the main work around ambiguous loss is being able to hold two opposing ideas together. So, like, I'm a caregiver and I'm a spouse. The person is here, but the person is not here, and sort of being able to live in these two different realities at different times is the challenge of caregiving. In terms of adult children, so you do see role reversal. Some people will talk about how they feel like they're becoming the parent. I don't really like to, I validate the feeling, but at the same time, no matter what, the person is still a parent. But there is that sense and that feeling of parenting your parent. Sibling issues are also very, very common. There are often, the real classic cases are where there's that one sibling who's usually, but not always, the daughter, and the one who's dutifully doing everything, and then the other siblings are nowhere to be found. There's that saying, one parent can take care, or one mother can take care of 7 children, but 7 children can't take care of one mother. So, those sorts of issues tend to come up. Sandwich generation issues, where you might have somebody who's taking care of elderly parents, and they have teenagers at home that they have to take care of, sometimes even younger children as well. And even if not, I find, especially in our community, even if it's not your children, a lot of people in the sandwich generation are taking care of, or watching their grandchildren for their children and taking care of their parents. Also, what has been found to be helpful is assisting with clear communication between family members, being able to find social supports, all have been shown to really help all people, all families, or enhance resilience, really, to help them become resilient with handling dementia. In fact, I mean, I run a support group for from adult children who are taking care of parents with dementia. And it can be really helpful to just have that place to, where you're with people, they understand what's going on. And, even just that, even if you're not necessarily solving anything, that somebody understands. There might be resources that they know about that can be helpful. These are all, and you can't do, as I mentioned, you just can't really do this alone. And as I keep mentioning, psychoeducation about dementia is really important to establishing resiliency. Being able to say to yourself, yes, the way my parent or whoever this is acting, it's not because they're out to get me. It's because, they have dementia and this is how their brain is being affected. So I'm going to say a little bit about Holocaust survivors and dementia. It's interesting because they may present with very similar symptoms as people with dementia, other people who are not survivors or do not have a history of trauma. But their symptoms of dementia are going to have a different meaning because they very well may be reenactments of trauma. So resistance to care is a very common one, not wanting to have any aides in the house, not wanting to, accept any help from anybody, not an unusual thing to see. It kind of makes sense in the context of somebody who has a background as a survivor because, you didn't really know who to trust. Preoccupation with food. It may not be about, forgetting to eat or things like that. It may be, back to they may be back in the camps or the ghettos where they didn't have food and being reliving those memories. And hoarding. I mean, for the same reasons, I think it's pretty self-evident. For survivors who are in long-term care facilities, they may have a really hard time with following the rules and have resistance to following the rules. They may have resistance to home health aides and rules that may be coming with those home health aid agencies. As I mentioned, they may be re-experiencing the traumatic memories. There may be more regular separation anxiety when family members leave. And that also can happen in the general population with Alzheimer's. But the thing is, when it comes to this separation anxiety, is that it may be more reality-based for them in terms of their experience, because they actually, did lose family members when they didn't see them again. So they may need a lot more reassurance and just reaffirming, this about safety. They also may bring up murdered family members around holiday times or family celebrations. I actually had a case where and this also is because the person that after a while, as dementia progresses, there's just no more filter or no more understanding of the context. But she would say to her daughter, why didn't they just kill me when they could? And because of the experience with dementia. And I mean, it was very difficult for the daughter to hear that. And it was sort of negating the entire life after the war, which, she was able to rebuild. So, they may bring up things about their Holocaust experience that's going to be distressing for the family members to hear. They may also bring up things the family members never heard about before. And that can be a whole other difficult situation for the caregivers to take on. So just also very briefly in terms of things to consider, and I'm not expecting that as rabbis or rebbetzins you're going to really be able to or need to coach people, but I do think these are guidelines that are helpful because a lot of times one might feel that it makes total sense to try to correct a person who has dementia in their reality testing or getting them oriented. The way we work, we do training for family members and home care providers. And our basic rule of thumb is, most importantly, is health and safety. But if a person, if a person is thinking that, they just had a conversation with their mother who has been dead for the last 30 years, and, the caregiver is thinking that they want to sort of say, grandma's been dead for the last 30 years, it may be better to kind of just, go with what they're saying, as opposed to say, and this is also, where somebody is insistent that they have to go to work or go pick up their children when it's, the afternoon at 3 o'clock and they're ready to like run out of the house and into traffic. That's already something that you really want to intervene more about. You want to keep the life story of the person with dementia in mind. That's where their head is. They're thinking about who they were when they're younger. Their occupation may be really significant to them. It may not be the best thing, for everybody to just be engaging in say like arts and crafts or something. If a person was a judge, they may find that demeaning. You may want to, give them, legal books to look through or something, or to sort or things like that, which they may feel more aligned or more familiar with. Not that they're going to necessarily take in anything they're reading, but it may at least give them that sense of dignity, like they're still important, and they're still, somewhat engaged in their profession, even if it's, not really, but they're identifying with their profession. You really want to do your best to help the person with dementia feel safe and heard. Really important to slow down and allow more time for response and activity. Especially when it comes to having a conversation, people with dementia often have trouble getting the words out, saying the right word, even just formulating what they're thinking. That doesn't mean that they can't, but they may need 20 seconds to formulate that sentence. And being able to kind of give them that time, at least to start seeing if they can do it before jumping in and helping them with words, it can be very validating for them. I'm actually seeing this right now. I run a early stage cognitive stimulation therapy group, and there is a very big difference. These are people who they're in the early stage, so they're still functioning pretty normally, but at the same time, once you get a dementia diagnosis, nobody really thinks about what you may have to say. And so in our group, we actually do discuss things like current events and reminiscing and just ideas about the world. And I think most of them really respond well to it, if only, I think there are a lot of things, but if only because we give them the time and the space to speak. And, there isn't any sort of rush to know things immediately or to say things and, very quickly. We really do give them the time. And so I think that's something that's very valuable and very affirming for them. And trying to do that, with people that we know with dementia is also very helpful. We want to adjust our own expectations. I keep talking about the importance of psychoeducation and understanding the disease and understanding how it's going to impact behaviors and things like that. It can really help to say, well, is what I'm expecting from this person really something that they can do? Or maybe they can do it, but they need some sort of adaptation or assistance to do it. You want to try to keep things simple. People with dementia cannot multitask at all. So you really want to keep things as one at a time. You want to avoid distractions for the same reason. You want to be reassuring, and also redirection can be useful. And we do talk about this more in our more in-depth family caregiver workshops, where we talk about dementia care and best practices with that. But in some ways, using a caregiver can use the memory loss to their advantage, because if they're able to redirect that person's attention for 2 minutes, they'll forget what they were talking about that was getting them anxious or agitated or things like that. So that's another technique to kind of use. And we also really do want to remember that when a person is agitated or when they're showing difficult behavior, they're not doing it because they want to be difficult. They're doing it because that's the only way they can communicate. If you have difficulty speaking, it's not going to get rid of how you're feeling. You're still going to have your feelings. You're just not going to be able to express them. they're going to come out some other way, and a person is going to act them out. So, we really do want to keep in mind, it's often, especially in medical facilities, they'll label behavior, label the person negatively because of their behavior when they have dementia, instead of really looking at, what, they're behaving this way, they're trying to communicate something, let's try to figure out what that is. So I'm going to take a little bit of time now to discuss what I've noticed in terms of how dementia is affected by Jewish practice. One thing that I think has really hit me in the face and really to realize, so much of what we do as Jews is time bound. Almost everything, our whole day is time bound. And it really makes things very challenging when it comes to dementia. And I would even argue it makes it more challenging than in the general population. If only because, just thinking about the days of the week, Shabbos is a huge hot button issue with dementia. A lot of times you may have people who will forget when Shabbos is. They may think that Tuesday is Shabbos and then get very upset when their wife is going out shopping. They may, have a lot of anxiety around Shabbos because they don't know when Shabbos is. And no matter how much you tell them, it's not going to sink in. So it's always like, oh my gosh, is Shabbos coming and Shabbos coming. And then that becomes an issue. Tefillah is also a big issue. A person, I've been hearing a bunch of stories where, you have men with dementia who are constantly saying they have to go to Ma'ariv, or they have to go, they have to go to shul. And it may be like, I don't know, 10 o'clock and the spouse and the aides are doing everything they possibly can to try to redirect their attention so that, they'll not feel like they have to keep going to shul. I've heard similar things about Havdalah where somebody with dementia, felt that they constantly it was time to end Shabbos and they had to do Havdalah. And there you have an issue, when it comes to fire safety. And it was also a really difficult thing to manage. Pesach is another one where things get very challenging. And I would also say that what the other thing is, in another way that it's different, around holiday time, like December time, there's a lot of material that comes up on different blogs and caregiving blogs about how to handle, dementia when it comes to holidays, and, the difficulties that happen and the sadness that, that the parent is not engaging the same way. We have that really every single week with Shabbos. I've had spouses who, find the Shabbos table very distressing because, particularly wives, because their husbands don't remember Kiddush anymore, or they can't follow Zmiris in venture. And it just becomes a constant reminder about the losses that are happening with their spouse. So I had a case recently also where, the person was caring for their father, and, the father is forgetting how to put on tefillin. These are all things that they're not just one-time things. These are things that happen every single day. So I think it just compounds the stress that our caregivers are facing, and people with dementia themselves are facing. So I don't know if there's anything we can do about it, but I do think it's a consideration that we really need to think about, because there just are so many more reminders about dementia that a from person has over everybody else. Other things to keep in mind, common shilas that tend to happen. I tend to tell people, what I do is I obviously I don't answer shilas. I also don't give people, sakim from my Rav on how to handle things. I do help clients in terms of trying to formulate, what should you be asking? Kashrus is a common one, especially around home health aides, especially around Pesach time. That was a big issue in terms of, can the home health aide bring in their chametz, and that can be a real headache for caregivers. Pesach in general can be a real headache for caregivers, especially if they're adult children, because they're usually double cleaning. And Shabbos in terms of, when is something an emergency? When can Shabbos be broken? How to handle asking the home health aide to break Shabbos are all things also that tend to be questions that people have. There are also questions regarding kibbud av v'em, especially when it comes to personal care. Can a child help a parent in the bathroom? or help them shower. I mean, I found there are different answers to, depending on who you ask, but these are all very important questions. If a parent is resisting care and the caregiver is trying everything they possibly can do to make sure that they're safe, to make sure that they're overseen, their medical care is overseen by a doctor, but the parents are just not willing, when can the caregiver just let go? And then there are other things which are not really shilas, but there are often, family dynamic and hashkafic differences that happen where, you may have a family member who, holds by one Rav who says one thing, and the other one says, has a Rav that says something totally different. And then it can become a whole mess in terms of that. Also, I don't really have answers to that. These are things that do happen. And I think, need to have awareness about. And so my last couple of points, end of life issues. I can't really go into in great detail, except that, certainly as from people, it is incredibly important to have a halachic living will and powers of attorneys. I'm sure that the Igud is having, I know the Igud has presentations on that. I've gone to some. But the other thing to keep in mind about the halachic living will, and this is back even to the hashkafic issue that I just mentioned, it's nice to have an agent. You have to make sure the agent is going to carry out what you want. So if you, have certain wishes, you really have to make sure that whoever your agent is going to carry out those wishes. You also have to make sure that that agent will hold by the Rav that you choose. These are things that I think have to be emphasized to people, that it's really important to choose the right people to do these things. And lastly, and I think this is something for Rabban and for community people as well, I think the community is really, really important when it comes to helping people with dementia and helping caregivers. And I think some communities are more open to, and by communities, I think I'm really talking about kahilas, different shuls do different things. I talk to many different people. I have some people where they'll say how, they're trying to find somebody to take, their parent to shul, their father to shul, and, they can't find anybody because everybody in the shul is afraid to take that responsibility. I could talk to somebody who's in a completely different community and they find people. They may have to pay people, but they do find people who are very happy to do it. So I do think if there's some way as a community where we could have, if in my dreams, it would be like to have like a dementia buddy system where you can have, Bachrim who, or even like, retirees who have time to take, men with dementia to shul. I mean, a lot of families are not comfortable having the father go to shul with a home health aide. But it can be really hard to find, a from person to take them. So, I think these are things that I find I get asked about, even, can we find a chavrusa for somebody who with dementia, that it really would mean a lot. And there are some people who are able to find in some communities and some people who are not, but there's no real centralized location to find your havrusas to help people with dementia. But those would be things that I think can be considered and might be something to think about for particular shuls, because there definitely is a major need for these sorts of things, and it really helps two people. It helps the person with dementia and it helps the caregiver. So a couple of other considerations for the rabbi. As I mentioned, you want to consider the life story of the person and also the place that Yiddishkeit has in their life. While they may not be able to do certain things, certain mitzvos or even minhagim might have really strong weight for the person. And we do want to consider to keep that in mind and not just, write it off as, oh, well, they have dementia, so they can't do it. As per my previous example about shul, these are really important things. I think one thing about these wandering situations, it shows what's important to somebody. It shows what they're thinking about. And I think when you're talking about in somebody and their biggest wandering concern is that, oh my gosh, it's time for shul, and that's where they're going. That's something that really holds a lot of importance to them. Likewise, Shabbos, I was once presenting to a group in Williamsburg, and they were talking about how, they work with women with dementia, and it'll be Tuesday, and they're talking about the gefilte fish that they have to make for Shabbos. So, we want to, if these are the things that are holding people's mind and where they're really at. We want to do what we can to keep affirming that. Another really important thing, I think this one is probably my most important piece, to realize that in social situations, even people who are in the middle stages, they can often hold it together in social situations, because the part of the brain that is responsible for social pleasantries is fairly intact until the very later stages. So they can still exchange pleasantries, they can still hold, seem like they really know what's going on because, they're pleasant. But I would say if a caregiver is sharing concerns with you about a parent's cognition or about a spouse or whoever, it should be taken seriously. I have had stories where people would go to their rabbanim about a parent, and the rabbi would say, I don't know what you're talking about. I've seen him and he's fine. He's fine. He's fine to me. He's fine because he can be social. So that's an important thing to realize. It's also really important to validate a caregiver's concern, to encourage them to get help and take time for their own self-care. I had a person that I was working with, and their community rabbi went to visit their mother, and at the end of the visit, which was very well received by the mother, the rabbi told her that he pretty much validated, these things are hard, and even if sometimes it's not unusual for caregivers to even have thoughts that thinking that the person's better off dead, and he just validated that, not that chas v'shalom you feel that way, but that is something that does happen. And for this particular person, it was really helpful for her to just have that space for the rabbi to validate how, even the negative feelings that come up with caregiving are there and something to be witnessed. So that's another example. And again, as I mentioned, for rabbi or other shul personnel, to try to see if there are people in shul who would be interested in assisting a caregiver by taking a person to shul or learning with them for an hour or things like that, would really make a humongous difference for many, many people. So in terms of CaringKind's programs, so our helpline is pretty much our intake line. That's our main avenue to get services. We do have social work services. I'm one of the social workers. We help with care planning, with figuring out the best action of care, how to get home care. Is a nursing home better? Should I keep the person home? Should I move them? I get a lot of calls about, should I move? My mom's in Florida. Should I move back to New York? Those types of questions. If a person is having a particularly difficult day and needs to cope, they can call us for that as well. Right now, we're starting a brand new coaching service for caregivers, which is much more focused on caregiving tasks and on a one-on-one kind of basis. So if somebody feels that maybe they need some skills to help with dementia care, they can certainly ask for that as well. We have support groups, as I mentioned. I have a support group specifically from caregivers who are adult child caregivers of dementia, of parents with dementia. But we have other support groups, and I know there have been from people who have joined the other support groups as well, and they can be very helpful. Our support groups are pretty much cohorted as spousal support groups or child support groups. We may have some additional types, which are like for siblings or for long distance caregivers. So if somebody is in need of a support group, they can most certainly call us. We just started our early stage services, as I mentioned, for people in the early stage. Those are all virtual. And they're these 1-hour sessions where we're really focused on helping a person with dementia, establish new ways of thinking, coming up with new ideas, new connections, engaging in a lot of different senses and music and in movement and things like that. These are evidence-based practices, so they've been shown to increase scores in cognition and in well-being. And I find that people enjoy them, and they're a lot of fun. And they're a lot of fun to facilitate as well. As I mentioned, we have family and professional education, which we have trainings for both family caregivers and home health aides. So if there are any family members who would like to be in a group for training around dementia care, they're excellent. We also have training for home aides. So if like somebody has an aide, they would like the aide to get more training, we do provide that. And for individual aides, I believe it's free of charge. If it's home care agencies, then a different service, but for individual aides, we do. We also have monthly educational workshops on every second Monday. And we also do regular understanding dementia workshops, which are basically like Dementia 101 for family members who, want to know more about it. Maybe if somebody was newly diagnosed or they're just starting to get an understanding of what dementia is. Those happen on every second Friday. I often am the one running them, but not always, not in the summer, but I will be continuing in the fall. So if anybody is interested, you can certainly let people know about that. As I mentioned, we have our Wanderer Safety Program with the Medical Alert Bracelet. And lastly, we have, and this is actually the fun thing that we do. I mean, everything else is about care. What's really, I think one of our most powerful programs is Connect to Culture, which is where we connect with different cultural institutions, museums, and have dementia-friendly programming. Right now, a lot of it is virtual, and we do it on Zoom. We've done things with different dance groups, with different orchestras, with different museums. We've actually also been doing stuff of Jewish interest. So we did a program with the Eldridge. We did a couple of programs with the Eldridge Street Synagogue Museum. Wonderful. And also the Jewish Museum. So it's helpful for people, they know that there's something, fun that they can do with their person, has nothing to do with care or with trying to like make things better. It's just an hour of just enjoyment. I highly recommend them. And again, for everything like this, you can call our helpline. You can also feel free to contact me directly. Here's all of my information. I also put Rabbi Blank's information down for anybody, who wants to follow up. We can talk about, for any individual inquiries, or if you have, congregants who can use some help, please, use us as a resource. And with that.
So I want to, on behalf of Rabbi Barachik, myself, you gave an amazing presentation. I think probably the theme would say, you're not alone. With all of these fabulous programs, and I know personally have worked with many families in my various positions dealing with family members with dementia and Alzheimer's. But there's so many other questions and Shiloh's. I am hoping to do follow-ups together with Adina, and we'll inform you as to what type of programs and presentations they will be. Please feel free to contact Adina about anything and everything about dementia that you might think. And don't think of any question being frivolous. There's no such thing as, it's not important. It could be very, very important, very helpful. So again, your presentation was phenomenal. It shows that people are not alone. There's so many different things to help everybody. And I hope that those who are watching this, in fact, I just received a text from a family member who's watching it, that the person's brothers in Israel is waiting to see the recording. So it's worldwide. Worldwide. Anyways, thank you very much, Adina, and thank you everybody for joining us. And again, we hope that feel free to call me at the number and email that was provided for any other programs and whatever we're working on, and to call Adina Segal and CaringKind for any help that you might need. Thank you very much and have a very good evening.
I'm just going to put my information in the chat again. I got a request.
Okay.